Good morning. Today we have the pleasure of hosting Dr. Britt Lunde for a talk on contraception for women with medical conditions. Dr. Lunde is currently an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and associate fellowship director for the Fellowship in Family Planning at the Icahn School of Medicine at Mount Sinai. She earned her medical degree at the University of Wisconsin and completed her OBGYN residency at the Mount Sinai School of Medicine. She completed a fellowship in family planning and earned an MPH in maternal child health at the University of Illinois in Chicago. Her clinical interests include long-acting reversible contraception and complex contraceptive and abortion care. Current research grants include the study of discontinuation of contraception by adolescents and immediate postpartum intrauterine device insertion. Please join me in welcoming Dr. Britt Lunde.
Good morning, everyone. Thank you for coming, and thank you for having me here to speak today. So I prefer a more colorful title of my talk this morning. Like these birds and bees, we're here to talk about the fact that women with medical conditions do it. So sex is a normal, healthy part of human relationships. But for women of reproductive age who have sex with men, that can put them at risk of pregnancy. And for women with medical conditions, there could be increased risks to their health or to the health of the pregnancy. So that's why we're here to talk about contraception today. My objectives for the talk are to help you consider pregnancy intention and contraception screening as part of routine healthcare for your female patients, and to help you become familiar with the CDC medical eligibility criteria for contraceptive decision-making, which is a really nice guide for use of safe medications for women with various health conditions. For my disclosures, I have a research grant from Teva, which is the maker of the Paragard non-hormonal IUD, studying immediate postpartum use of IUDs. And then I'm an unpaid trainer for Merck, which is the company which makes the contraceptive implant that we'll be talking about today too. So why is this an important topic? Why am I here? Unintended pregnancy is a public health problem in the United States. This is data from 2008 from the National Survey of Family Growth and from the National Abortion Patients Survey, showing that in 2008, of 6.7 million pregnancies for US women, 52% of them were intended and 48% of them were unintended. The National Survey of Family Growth has been updated, and results came out just recently showing that the percentage of intended pregnancies has increased slightly in the US. So the most recent number in 2011 is 55% of pregnancies were intended, which is great. We're moving in the right direction, but we're still well behind Canada and other European countries where more like 1/3 of pregnancies are unintended. I kept this slide from the 2008 data because I wanted to look at the different types of unintended pregnancies. The survey asks women, when you became pregnant, did you want to become pregnant then, later, or never? So women who said, yes, I wanted to be pregnant when I became pregnant, or sooner, so if they were trying to get pregnant, had an intended pregnancy. Women who said, I would want to be pregnant in the future, but not now, those pregnancies were categorized as mistimed. And there's a big range there, right? That could be a woman who just got married and would prefer to delay childbearing for a year or so, or it could be a teenager who wants to be a mother in her 20s or 30s, but doesn't want to be pregnant right now. And then those pregnancies that are categorized as unwanted are those that happen for women who don't want to have any more children or didn't want to have children at all. And if we look at the outcomes of those unintended pregnancies, so the light blue half is still those pregnancies that were intended. The left half, as you're looking at it, is those pregnancies that were unplanned. And we see that about 40% of those end in abortion, and almost half of them continue on for delivery. The gray area is those that end in miscarriage. So intended pregnancies, we know, are healthier. Women who want to become pregnant when they are pregnant are more likely to have adequate prenatal care. They're more likely to breastfeed. And following those children, we see that the children have better childhood health and educational attainment. There's less smoking and drinking. Women who want to become pregnant can plan ahead to stop those behaviors and reduce risk in their pregnancy. And intended pregnancies are also associated with less low birth weight pregnancies and less depression and domestic violence. So this problem of unintended pregnancy is frustrating for those of us who work in contraception because we have good methods to help women prevent unintended pregnancy. This is looking at the pie on the left is women at risk of unintended pregnancy. So those are women who are currently having sex with men but do not want to become pregnant. So they're at risk of pregnancy that they do not want. And that was 43 million women in the US at the time of this survey, published in 2009. And we can see that the majority of women, this is the this blue section here, are women who are consistently using a method of contraception. So remember, they said they don't want to become pregnant. So they're using something to avoid pregnancy. And we can see that those 65% of women contribute only a small number of the unintended pregnancies. Contraception helps them avoid an unintended pregnancy. Then we see women who are using a method but inconsistently, is about 20% of the population, and they contribute about 40% of the unplanned pregnancies. So these are women who are using condoms, but not every time, or women who are on the pill, but might forget it, or might not be able to fill it at the end of the month because they lose their prescription or their insurance runs out, other things that get in the way of using a method consistently. And then it's a small number of the women who are at risk of unintended pregnancy and not using any method, but not surprisingly, they contribute a large proportion of the unintended pregnancies, more than half. So this is a list of all of the methods of contraception that we have available and the effectiveness of each method. I've listed both the ideal effectiveness, so used under ideal circumstances, used perfectly, and the typical effectiveness used in the real world. And that pink line there you can see is a dividing line between the methods above, which have very similar ideal and typical failures, and those below that have a much higher typical failure rate because they are user dependent. So the pill is a very popular method, and it's a good example here. If we use the pill perfectly, take it every day, don't forget it, start every month, it works very well. But for women in the real world who have busy lives and might not be able to remember to take that pill every day, the failure risk goes up. So these methods above are those that don't require the user to do something every day for them to function. And so I'm going to go through and talk about these different methods. If at some point I'm talking about a method that you're unfamiliar with, please feel free to raise your hand and ask as I'm discussing it. I don't want to wait till the end if there's a question on a particular method. So at the very top is the contraceptive implant, which is a progestin-only subdermal insert, which is placed underneath the skin in the arm and lasts for 3 years. These are all very similar effectiveness. You can see there's not a lot of difference between these. One thing that surprises patients and a lot of people is you see both male and female sterilization here as very effective methods, but equally effective to these other reversible methods that we have and not more effective. So a tubal ligation is good, but it's not better than an IUD or an implant. So then leave-in-a-gestural IUD is a progestin-only IUD, and there's 3 of these available right now in the US. This is the brand names Mirena or Skyla, and a new one on the market named Liletta. Those 3 different kinds of hormonal IUDs. Depo-Provera is also progestin-only contraceptive injection, which is given every 3 months. Female sterilization, and the non-hormonal copper IUD, which is the Paragard. And then these are all methods that require the user to do something, either every day with a pill, every act of intercourse with the condom, withdrawal, diaphragm, and periodic abstinence is the calendar method. So you can see even that one is pretty good if we can use it perfectly, but it's hard to use perfectly, and so the failure rate in a typical year is about 25%. So those are all the methods we have available, but what do women in the US really use? This is results of, again, the National Survey of Family Growth, looking at women ages 15 to 44, reproductive age. And the most popular method in the US is still the oral contraceptive pill. About 25% of women use that. And then the pink piece is the female sterilization, again about another 25%. Condoms here for 15%. LARC, which is long-acting reversible contraception, includes the contraceptive implant and the IUD. Long-acting because they can last for years, but reversible because they're removable and women can become quickly pregnant after they're removed, is about 11% in the most recent data. And this is a huge jump. 15, 20 years ago, it was more like 2 to 3% of the US population. So those of us who work in contraception are really proud of this increase in this piece of the pie. And you can see male sterilization is a less common, but also another piece there with about 8% of women relying on their partner's vasectomy for their contraception. As we talk about the different kinds of contraception for today, another important way to look at it is the hormonal contents, because that can help us understand the different health risks and contraindications potentially. So if we group by the hormones that each method contains, those that contain estrogen and progestin are the majority of oral contraceptive pill formulations, a contraceptive patch and a vaginal ring. Progestin-only methods include the implant, the hormonal intrauterine devices, the injection, and there is one progestin-only pill on the US market. And the non-hormonal methods, which are the non-hormonal copper intrauterine device, condoms, and then the surgical permanent methods for men and women. So as we're looking at women with medical conditions, we want to consider the effects of pregnancy on their health, the effects of their health on the pregnancy and risks associated with their medical condition, and medication side effects as well when we're talking about pregnancy planning, looking at medications that may be contraindicated in a woman who's trying to become pregnant. So we said that women in the US have a high risk of unintended pregnancy. How about for women who have medical conditions, for those who are at higher risk of health problems in pregnancy? This is a study that was done by my co-fellow at the University of Illinois, looking at data from Florida. It's done in all the states, but states ask different questions. And in Florida, they ask about pre-existing health conditions for the mother. So hypertension, diabetes, asthma, common health conditions. And in the year 2004, they looked at over 4,200 deliveries and found that 44% of the pregnancies were unintended for healthy women. But for women who reported a history of a health condition, even more of them had an unintended pregnancy. Almost 60% didn't want to become pregnant at the time that they became pregnant. And I should say, I really like this survey question because it asks the woman about what she wants. It isn't someone else's idea of how many children someone should have or if her health is optimized. It's does she want to be pregnant at the time this pregnancy happened. So my co-fellow Julie then asked women how they consider their contraception and family planning in regards to their medical condition. And she interviewed women. This was a qualitative study done, women at the University of Illinois who were treated for hypertension and also a range of cardiac diseases in our cardiology clinic. And she described a spectrum of integration, that some women do not integrate the two concerns at all, their family planning needs and their health condition. So an example of that was a woman who said, the birth controls, truthfully, I forget them, but with my high blood pressure pills, I won't forget, for the simple fact that I know that's dealing with my health. So she's concerned about her hypertension, and she'll take those medications, but she doesn't see the link between contraception and avoiding a pregnancy and her health. Other women had a high level of integration, and this was described by a woman who said, I wanted some form of birth control because it's not good for my blood pressure to keep having babies because it's getting worse and worse as I get pregnant. And that's why she chose the Mirena, one of the progestin long-acting IUDs, which is a very effective method. So women may or may not see this as important to their health, and they may or may not be thinking of it as they're coming to you for care for their chronic medical conditions. So that brings me to a study which was what prompted me to email your department and ask if I could come give this grand round. So this is a recent publication from our main OBGYN journal in 2015, looking at contraception use among women with medical conditions in a nationwide private insurance health database. So we saw from the Florida study that women with health conditions may be at higher risk of unintended pregnancy, which then leads to the question, how do we do then for providing contraception for women with health conditions? They looked at this database from October 2010 through 1 year later in 2011, and they reviewed the medical record of women in reproductive age for their use of female sterilization, IUDs or implants, and prescription contraception. So this was the overall population that they looked at. There were 360,000 total women, and for analysis purposes, they broke it up into those between ages 15 and 34, and those 35 to 44, so still of childbearing potential, but potentially decreased fertility, and more likely probably to have health conditions as they're getting older. There were 10 different health conditions that they looked at, and found that 12% of the population overall had one of the health conditions. And the two most common were hypertension, about 10,000 women in this database, and diabetes, another 10,000 women in the database. And you can see here that the younger women had less hypertension and diabetes, and the older women had more, which makes sense. They excluded women who had a history of hysterectomy in their medical record, which makes sense because those would be women who are not at risk of a pregnancy. And they looked at the use of contraception by these women. So here is the younger age group, women 15 to 34. We can see that in that age group, the healthy women had a very low reported use of female sterilization. They are younger, potentially still want to have children. But we can see that even in this young age group, more women with hypertension and diabetes were using these methods. So this could be good if that's what the woman wanted. So if her health condition leads to risk in pregnancy and she's done having children, female sterilization is a very effective method to help her prevent a pregnancy. But we're seeing in the US that many women want to delay childbearing and are waiting until their mid to late 30s or even 40s before they want to become pregnant. And sterilization is different from the other methods because it is permanent, and it takes away that possibility of future childbearing. So looking at those methods, the long-acting IUDs and implants, about 3% of women in the overall database were using it, and more by the women with hypertension and diabetes. So this is good too. And then you can see that again, the pill is mostly driving this, that's a very popular method, and that half or more of the population were not using any surgical or prescription method. So this isn't the same group of women from one of those earlier paragraphs where I said these are all women who don't want to become pregnant right now. This is all women in the database. So we're not including women who are not at risk of pregnancy because they're not partnered with men, women who are trying to become pregnant, or those who are using a non-prescription method like condoms for their contraception, or people who rely on their partner's vasectomy. So we can't really say, this is really high, 60% of these women aren't using contraception. It's not a fair evaluation. It's lower than the total that actually need contraception right now. So this is pretty good, actually. This is showing that in the younger age group, more women with health conditions are using contraception. And then if we look at the older age group, I'll find my pointer here. So these are women 35 to 40. And here we can see more women now are using sterilization as they get older. And that's a common thing that we see. Older women are often candidates for sterilization when their family is complete. More women, but still a very small percentage using long-acting methods. And here, much fewer of them using the shorter-acting methods, again, largely driven by the pill, and having to do, I would imagine, with concerns using estrogen in women who are older with health problems. But even in those healthy women, a low use of the pill. So the takeaway for me here is that these numbers are good, but still a small percentage of the women are using the more effective methods. And especially looking at alternatives to sterilization, the goal of the rest of my talk today is to make you more familiar and comfortable with these other types of contraceptives, the long-acting methods, to help be comfortable when your patients ask you, what do you think about this, that these can be good methods for these women. Okay, so how do we have this conversation with patients? You have a busy office visit and you have many things to worry about. So there's a screening question that's been proposed called the One Key Question, which is recommended by ARHP, the American Reproductive Health Professionals, and the American Academy of Family Physicians, among others. And the question is, would you like to become pregnant in the next year? Get very wide response differences here. So someone might say, absolutely yes, and in fact, I'm trying right now. So then that can help guide your conversation to looking at her, the state of her health and any medication she may be on, and potentially a referral to us for a preconception health visit. She might say, very definitely not. And then that can help, again, with a referral to us to talk about her contraceptive options. And a lot of women will say, maybe. So the idea that women are not totally yes or totally no, and there might be a lot of conflicting reasons for or against a pregnancy right now. This is a huge topic of study in our field, trying to understand better people's planning and desires as far as pregnancy and how that affects their health behaviors as far as pre-pregnancy planning and prevention. So I don't expect that many of you are going to be, recommending specific methods or discussing with your patients or offering them contraceptive necessarily, but bringing this up as an important topic for their health can help get them thinking about it if they're not already, and then we are happy to see them to help decide on a method of contraception for them. Oh, and then this, so just talking about the commonality of ambivalence in pregnancy, this is one of my favorite prescription methods of birth control. I've actually never prescribed it, but I just love the idea. So I don't know if you can see there, but this one is called B-Yaz, Yaz being one of the prescription methods, and the B is because there's folic acid in this birth control pill. So if your patient is not sure if she's going to keep taking her pill or if she's going to stop it because she might want to be pregnant soon, she can get both her folic acid and her oral contraceptive in the same pill. All right, so for the rest of the talk, we're going to look at the CDC medical eligibility criteria, which are a really nice user-friendly guide to help us understand the information that's available about safety with contraception. Has anybody looked at this or used it? A little bit. Okay, I'm glad to see someone has, and I'm glad to see that there's a point in me being here today so I can help you take a look at this and hopefully it'll be useful. The medical eligibility criteria is a document produced by the CDC. It's available online, and then there's an app. You can search for US MEC. It's based on WHO medical eligibility criteria for contraception, but was adapted for use first in the 2010 when it was published, and then is updated periodically as more data becomes available. The recommendations are made by working groups that include experts on contraception, but also experts in the field for the health condition. So when they made the recommendations for diabetes, they had endocrinologists at the meeting. And they publish their findings as systematic reviews. So you can look at their recommendations, but you can also find the link to their source documents to understand why they made those recommendations and decide if you agree. And they make recommendations for a long list of medical complications. So these are medical conditions that they decided would put women at increased risk for adverse health events as the result of an unintended pregnancy. And you can see it ranges from breast cancer to liver disease, cardiac disease, organ transplant. And so recommendations are made for all of these health conditions. And the recommendations are made in a list of categories 1 through 4. So a 1 method being those that are safe to use without restriction. A method that is category 2 being one where the advantages usually outweigh the risks. And that's a lot of methods end up being category 2, but that's a lot of medicine, right? So there are risks to medications that we use, but the benefit of preventing an unintended pregnancy would outweigh those risks. A category 3 is a caution, so there for that woman with that health condition, the risk usually outweighs the health benefit, and another method would be recommended. And then a category 4 are those that have an unacceptable health risk to the woman with that condition. And just for the purposes of our beautiful Mount Sinai slides, you'll see the rest of them are going to be 1 and 2 are blue, and 3 and 4 are pink. So here is the app. And there's a lot of great apps from the CDC with vaccine recommendations and things. So this, if you search CDC, you'll find a bunch of good ones, but this is the contraception app. And when it starts out, you can look either for a summary, and this is based on her medical condition, or the guidelines per method. I usually use this one because I usually have a patient in the office with condition X, and I want to know what's safe for her. So this is the more clinically applicable of the two that you can click on. And then here, if you pick that button, you'll see the list of all of the conditions that they're going to make recommendations on. For this, I clicked on rheumatic diseases, and then you can see either for lupus or arthritis. And when you go to the actual recommendations, the categories here, COC is combined oral contraceptive, patch or ring. So this first line is all those estrogen-containing methods. Progestin-only pills, Depo-Provera, implants is progestin-only implant, IUD, and the non-hormonal IUD. So then these are all links too, and you can click on, you can see the numbers for each method in this health condition, and then you can click on it to see the explanation. So for example, why is there a 2 or a 3 for Depo-Provera, and what does that mean? If we look there, and then continue to click through, we see potentially that there is a category 3 here. And if we go further, what's that explanation? So Depo-Provera has been associated with decreased bone density, and this is saying for women who are on a long-term corticosteroid as treatment for their arthritis would also have increased risk of low bone density, so you wouldn't want to combine those two. But for women with these health conditions who are not on a long-term corticosteroid, that interaction isn't a concern, and then the injection becomes a category 2. So a lot of detailed information that you can get from this app just by clicking through. Okay, so now we're going to look at the recommendations specifically. I chose hypertension, diabetes, and thromboembolic disease because I figured those might be common conditions that we see for women who are of reproductive age. When we talk about hypertension, important to consider the risks in pregnancy for a woman with hypertension. Women are at increased risk of preeclampsia, of placental abnormalities, placental abruption, fetal growth restriction, which all can result in preterm delivery, and then also to consider medications for hypertension, which may be contraindicated in pregnancy. And the main one that we worry about is lisinopril. Any ACE inhibitors can be teratogenic in the first trimester. So if a woman is planning on becoming pregnant, we'd want to stop that medication for her. So we know that estrogen can increase hypertension. Combined hormonal contraceptives increase the blood pressure about 5 to 10 systolic and diastolic. And there's an increased risk of stroke associated with estrogen and women with hypertension. So that explains why the estrogen methods get categories 3 and 4 in these recommendations. So remember 3 and 4 being those that are usually not recommended and those that are absolutely contraindicated. And the severity gets worse as her health condition gets worse with hypertension. But you can see that all the other methods which don't contain estrogen are categories 1 and 2. Depo-Provera is one of the progestin-only methods that you'll see a difference in the recommendations. And this is because the injection progestin is a high dose that can lead to a hypoestrogenic effect, which then can lead to concerns about potential cardiovascular risk and HDL levels. So you'll see this, even though it's a progestin-only method, sometimes the Depo injection has a different recommendation than all the other progestin methods. Just as an aside, we talked about how we wouldn't want to have a woman on an ACE inhibitor if she was planning pregnancy or in the first trimester. And this was a study done in 2007 looking at how good are we at documenting that we're using contraception if we're prescribing a potentially teratogenic medication to a woman of reproductive potential. This was another medical record review looking at nearly 5,000 women. They looked at women in the health system who received a prescription at that visit, and then looked at the classification of the prescriptions for their pregnancy category, A, B, D, or X. And I think this was done in the Kaiser system is where this review came from. So they looked at women who filled a prescription in the time, and you can see that very few women got a Class X medication, but that we weren't any better whether we gave them a Class A or a Class X recommendation at documenting a discussion in the medical record about asking them if they're on birth control, letting them be aware of the potential teratogenicity of this medication. And I think this is interesting, from a health standpoint, but also from a CYA standpoint. If we're writing these medications, we want to be careful that we're adequately counseling our patients. So the one medication that they found that did much better than the others was the acne treatment. And for anyone who's seen this or prescribed it, it's often given to young adolescents, right, who are fertile and at risk of unintended pregnancy. And the patients have to sign a pledge and understand that they would be at risk of problems in pregnancy if they became pregnant. We get a lot of referrals of young women coming to say, I want to start this medication, but my doctor told me I need birth control before I do. So that's the one method where the drug company has actually done a good job educating providers to help reduce potential complications from this drug being prescribed to someone who then becomes pregnant. Kind of off to the side a little bit, but because I'm here and this is a recent change, the changes in those drug labeling for pregnancy and lactation have just come into effect in June of 2015. So you're gonna, if you look at recommendations for pregnancy and lactation, you're gonna start to see different recommendations. They're getting rid of those categories A through X, and they've added a new category, females and males of reproductive potential, to actually address this issue of people who could become pregnant while they're on the medication. And there are not gonna be these 4 categories anymore. It's not gonna be A, B, D, or X. They're just going to present the information. They're going to say, here's what we know about the risks, here's what's been studied, the data that's available, and then we're going to need to decide. I think this is more useful. Those categories lump a lot of different kinds of data together, and we don't have a lot of good data on very many medications in pregnancy because those studies are difficult to do ethically, and a lot of our studies come from animal studies and then extrapolated to human data. So we're just going to get now, here's the data, talk to your patient, decide what you want to do with this medication. Okay, so next, moving on to women with diabetes. Women with diabetes who become pregnant have a higher risk of fetal loss, both miscarriage and stillbirth, and a higher risk of congenital anomalies that is directly related to their pre-pregnancy control of their diabetes. So women who have good control, who have a normal hemoglobin A1C, have a risk of birth defects at the population level, 2 to 3%. But in studies, if the diabetes is not well controlled, you can see a very high risk, up to 20% risk of birth defects in women who have poor control of their diabetes pre-pregnancy. So planning can be very important for these women, and it can help motivate them to get their diabetes better under control if they're planning a pregnancy to help reduce the risk to their pregnancy. They also have increased risk of preeclampsia and all those health conditions that we discussed associated with preeclampsia for the women with hypertension. So medications for diabetes themselves are not contraindicated in pregnancy, and we use insulin and glyburide and metformin all the time in our pregnant patients. But here again, to think about the ACE inhibitors, which are often prescribed to women with diabetes, which can be teratogenic. And here is the table of recommendations for women with diabetes. So like hypertension, they made recommendations based on disease severity, and the recommendations change. The estrogen methods being the outliers again. So in women who have end organ disease from their diabetes or long-standing disease, the estrogen methods are cautioned against or not advised at all. And again, we can see the concerns with Depo, but all of the other methods, the progestin-only methods and the non-hormonal methods, categories 1 and 2. So lots of safe, effective options that women can use. All right, and then the last health condition that I wanted to draw attention to is women with increased risk of venous thromboembolism. This is something that we see patients refer to us a lot or come to us with an unplanned pregnancy because they thought there weren't any safe methods for them to use. So in the general reproductive age population of women, the risk of a thromboembolism is about 4 to 5 per 10,000. With oral contraceptives, EE is ethinyl estradiol, so this is the combined oral contraceptive pill. The risk doubles. In pregnancy, the risk is about 30 per 10,000 women, and immediately postpartum is the highest risk time for these women, 300 women per 10,000. And so these are women who don't have a pre-existing condition, then are much higher for women who have a history or a genetic risk. Medications that we might use to treat history or a current thromboembolism, warfarin is also contraindicated and teratogenic in pregnancy. So this is something that there's a lot of confusion about because the FDA labeling for the progestin-only methods are confusing. If you read the label for Depo-Provera, for IUDs and implants, it says that estrogen-containing methods are associated with DVT. These methods are progestin-only, but essentially we're extrapolating to the estrogen-containing methods, and so we don't recommend these methods for women with a history of DVT. So if she reads through her labeling, it's going to say the FDA says you should not use this medication. But based on studies, the progestin-only methods do not increase the risk for women of a thromboembolism. And we were all very happy when the CDC made these guidelines, because now instead of me saying, look, here's the data, here's the studies to the patient, I can pull up this nice little chart, which is a lot easier for the patients to look at, and say the CDC recommends that these are safe methods for you. So again, here we have the estrogen-containing methods, the combined hormonal methods, being absolutely contraindicated or strongly cautioned against, but all of the progestin methods being category 2 or 1, that the benefits likely outweigh the risks. And because there's so much confusion with the labeling, I just put up here the results from the meta-analysis. And so you can see these are looking at all progestin methods and looking at 7 different studies and showing that in all of these studies, potentially small sway either way, but when you combine them together, that there's no increased risk of clotting disorder. So good data, good recommendations, good guidelines to help reassure women that they can use progestin-only methods to help prevent pregnancy and not put them at increased risk of clotting. Again, we have the question, is Depo-Provera different because of the hypoestrogenic effects? And that is something that we need a little bit more information on. So only 2 studies looking specifically at Depo-Provera. And here, because a larger study showed a slightly increased relative risk of clot, combining these 2, that there could be an increased risk. So again, to look at what progestin-only methods are available besides the Depo as a potential health risk for her. All right, so I'm going to wrap it up there and leave room for any questions about anything in the talk. Thank you all again.
Thank you. Questions?
The SSRI, pregnancy, and depression. So lots of young women on antidepressant medications. I know it's controversial, but how do we counsel them when they say they're thinking of getting pregnant and they're on antidepressant medication?
Yeah, so that's an important question and a difficult one. And recently, those questions about the pregnancy categories, the A, B, D, and X, have caused some increased confusion for all of us because some methods were a higher, a B category, but they didn't really have any more data than the others. So I don't know why they ended up with a B category recommendation. And if you're seeing someone like that, I would recommend a preconception counseling visit with our high-risk OB doctors to discuss. And it's really an individual potential risks and benefits, looking at medications that have worked for them, and what's the the risk of their recurrence during pregnancy or postpartum too. So a very individualized discussion, I think.
So, with the recent war on Planned Parenthood in certain states, I'm aware that in at least one area that there's an increased incidence in HIV. Do you know anything about the incidence of unwanted, unplanned pregnancy?
Yeah, so our colleagues in Texas have done a lot of studies because they've been hardest hit the longest at losing their Planned Parenthood funding. And they haven't shown unintended pregnancy changes yet, but they have shown that women are less likely to continue their contraceptive methods. They looked at women who used Depo-Provera, which requires every 3 months coming back, and those women who are relying on Planned Parenthood in Texas are now much less likely to continue their method because they don't have access to it. And we can then extrapolate from that. If they can't get access to their method, they're going to be at risk of unintended pregnancy, definitely.
Actually, there's a very interesting article in the New York Times about a week, 2 weeks ago, that looked at the states, color-coded states that had decreased funding for abortion, and looked at Google searches for do-it-yourself abortion, and it overlapped completely. So, a little frightening. Not a little, a lot. So, thank you very much. Thanks very much.
Thank you all.